Where is my aorta and what does it do?
The aorta starts in the middle of the chest, moves up towards the back, and then down the back into your belly.
The aorta is the major artery that comes out of the heart and delivers blood throughout our body.
Well, the aorta is this big artery that comes right out of the heart, and it goes kind of north toward our chin and then down the back, kind of looks like a candy cane.
Think of the aorta like a big highway, and instead of cars going through it, it has blood going through, and it's connected to smaller roads, which are the mid-sized arteries, and that's how blood gets around to the body.
Why is my aorta so important?
I think that's pretty obvious from the last question. If you didn't have an aorta, you'd just be a puddle of blood.
What is a thoracic aortic aneurysm?
An aneurysm refers to dilatation or enlargement of a blood vessel to 1.5 times the size it's supposed to be. And when we talk about a thoracic aortic aneurysm, we're talking about an aneurysm of the aorta within the chest cavity.
A thoracic aortic aneurysm is when the part of the aorta that's in the chest is larger than it should be.
A thoracic aortic aneurysm is an enlargement or widening of the aorta, the biggest blood vessel in the body, when it comes out of the heart and in the chest.
A thoracic aortic aneurysm refers to an enlargement of the aorta, and that can occur in a part of the aorta just above the heart. That's called the ascending aorta, or up on top when it turns. That's called the arch of the aorta, or as the aorta goes down the back and serves all of the arterial branches to the various organs. That's called the descending aorta.
What's the difference between thoracic and abdominal aortic aneurysm?
The aorta is divided into different regions based on where they are in the body. So if it's in the chest, it's called the thoracic aorta. If it's in the abdomen, it's called the abdominal aorta.
What is an acute aortic dissection?
An acute aortic dissection is a tear in the lining of the aorta, the largest blood vessel in the body, that can develop suddenly and unexpectedly.
The aorta has 3 layers to it. The inner lining of the aorta can tear, and blood gets into the media.
And it then moves downstream, essentially peeling the lining off on the inside.
And actually separates the aorta from being a single tube to being 2 tubes.
And that peeling of the lining can also compromise blood flow to branch arteries that come off the aorta and cause harm.
And there's the normal place where the blood flows, and then there's what we call a false lumen where the blood is. So an aortic dissection is an acute, typically aortic catastrophe, which we want to diagnose and manage very, very quickly.
What is the difference between type A and type B aortic dissections?
¿Cuál es la diferencia entre disección de aorta de tipo A y tipo B?
And this is a classification system that developed from a group of surgeons and cardiologists at Stanford.
Type A aortic dissection starts in the ascending aorta. That is the first part of the aorta coming out of the heart.
The type A aortic dissection means that the tear in the aorta is in the ascending part. So you have the heart squeezing, and then the aorta just above that. So the oxygenated blood is coming out of the heart into the aorta.
Type B dissection is any dissection that happens in the aorta other than the ascending aorta.
The Stanford group basically defined the type of aortic dissection that happens in the more distal part of the aorta, typically after the arch, as the aorta traverses over what we call the arch and then down. There's a spot there where sometimes the aorta can tear, and we call that a type B aortic dissection.
How common are acute aortic dissections?
Thankfully, it's very uncommon. We don't know for sure the actual incidence of acute aortic dissections, but in the United States, it's probably somewhere in the 10 to 20,000 range. Acute aortic dissection is a relatively rare event as you think about a population. 20,000 is still a lot of folks that get this terrible problem.
If you filled a small baseball park with fans and you said, one of those people will have an aortic dissection in the coming year. That's a good way to estimate the rate of aortic dissection.
And obviously, we need to do a better job of identifying the factors that cause aortic dissection and hopefully a better job at preventing them.
What are the symptoms of an acute aortic dissection?
Acute aortic dissections are often missed because the signs and symptoms, including chest pain, are similar to other reasons why people might go to the emergency room.
I was driving my car and it felt like somebody took a dagger and stuck it right in my heart while I was driving.
The reason aortic dissection can be misdiagnosed is because the symptoms are so nonspecific. They can mimic other diseases.
I felt a pop, and then I felt this gush in my chest. The weirdest feeling. I'd never felt anything like it before.
I woke up that morning with searing back pain.
Pain started to go down my jaw, and I started to feel really numb.
It started moving down to my leg, and my right leg went numb. And that's how I knew something was really wrong.
And then I started to feel pretty nauseous. My stomach was really upset. I was just off.
And that pain continued and got worse in seconds, not minutes.
I couldn't really describe exactly what it was, but I had a feeling it was going to kill me.
He was in the hospital for 24 hours for a workup for low back pain until somebody had the brilliant idea to do a chest x-rays, and they saw the widening in the mediastinum, and luckily the patient survived operation and the back pain disappeared, of course.
Why are dissections so often misdiagnosed?
Acute aortic dissections are often missed because the signs and symptoms, including chest pain, are similar to other reasons why people might go to the emergency room.
Aortic dissections are considered the great masqueraders sometimes. People show up with chest pain, and if they're a young patient, maybe they'll think the patient's having a pulmonary embolism, which is a clot in the lungs.
The reason aortic dissection can be misdiagnosed is because the symptoms are so nonspecific. They can mimic other diseases.
Aortic dissections, it's like trying to find a needle in a haystack sometimes.
So many people come to the emergency room with chest pain. You really have to be thinking about an acute dissection to diagnose it. Often it is misdiagnosed as a heart attack or clot in the lungs or a stroke or other serious illness. So we really need to be thinking about the aorta in order to diagnose acute dissection.
How can aortic dissection be diagnosed?
The best way to diagnose an aortic dissection is with a CT scan. And oftentimes a CT is done for another reason, and on the CT scan we see the aortic dissection.
Think aorta.
The emergency room physician had a hunch that it wasn't a heart attack, but something else. And in order to prove his suspicions correctly, he sent me for a CT scan.
Think aorta.
If you have a family history of aortic dissection or a genetic condition that can predispose to acute dissection, and you're in the emergency room with sudden onset, severe chest or back pain, then ask for a CT scan.
Think aorta.
When the ambulance delivered me to the ER, the physicians assumed that I was having a heart attack. After my vitals crashed, I had to be intubated. Someone brought up John Ritter and decided that I needed a CT scan.
Think aorta.
Can a type A dissection be prevented?
The type A aortic dissection can, of course, be prevented primarily through awareness of the presence of aneurysms and of underlying diseases and family history of an aortic dissection. The principal way of preventing aortic dissection is prophylactic surgery to replace the aortic root when the feeling about the risk of dissection is high enough to justify the surgery. Medical therapy is also important.
Minimize the pressure on the aortic wall. So taking the blood pressure on a daily basis, ensuring that the systolic's less than 130 is what I usually recommend for my patients. That can be achieved through a variety of medications, usually beta blockers, ACE inhibitors, and sometimes calcium channel blockers. But working with your doctor to coordinate a drug regimen that works for you is ideal. Number two is exercise restrictions. So what we want to try and minimize is, once again, pressure on the aorta. So lifting heavy weights is not recommended. Depending on your body size as well as your aortic pathology, your doctor will give you personalized exercise recommendations and restrictions that you should abide by. And obviously, avoiding any illegal drugs that may cause high blood pressure scenarios.
What kind of genetic syndromes put someone at risk?
The incidence in individuals with underlying genetic aortic disorders is much higher, and that incidence depends on what the specific disorder is.
There are different types of genetic or heritable thoracic aortic aneurysm diseases or conditions that place someone at risk for aortic dissection. And we like to divide those up to those that have outward features, or we call syndromic heritable thoracic aortic diseases. And these have recognizable features, like in Marfan syndrome, or Loeys-Dietz syndrome, or vascular Ehlers-Danlos syndrome, or Turner syndrome. In another broad category, which is probably even much more common, those without recognizable outward features. These are called non-syndromic heritable thoracic aortic aneurysm conditions. And many genes associate with non-syndromic conditions.
Is pregnancy a risk factor for aortic dissection?
I was 37 and a half weeks pregnant when I had my type A aortic dissection.
Aortic dissection is not a common event in pregnancy. However, studies have shown that pregnancy is an independent risk factor for aortic dissection. It's even a higher risk in women who have a known gene or a syndrome that is related or causing a disease in the aorta.
Hormone changes that normally occur in pregnancy can put you in jeopardy if you're at higher risk.
I had a C-section and my aortic surgery on the same table.
In younger female who are pregnant or after delivery, the pain and the symptoms can sometimes be mistaken as pains that are related to the labor and the delivery itself.
The normal monitoring that we'll use to watch your aorta during pregnancy are echocardiograms, which are ultrasounds we do of the heart, and MRIs, which use magnets to make images of your entire aorta. In emergency situations, regardless of whether you're pregnant, a CT scan is the best test to do to figure out if you have an aortic dissection. There is potentially a small dose of radiation that goes to you and the baby, but in finding out that there is an aortic dissection is vital for your and your baby's life.
¿Qué es una válvula aórtica bicúspide?
What is a bicuspid aortic valve?
The aortic valve regulates the flow of blood from the heart to the rest of the body. A normal aortic valve has 3 leaflets. On profile, it looks like a Mercedes-Benz logo. Occasionally, 2 of these leaflets are fused, which would make it into a bicuspid as opposed to a normal tricuspid aortic valve. Patients with bicuspid aortic valves have a higher risk of developing valvular disease. This can be narrowing or stenosis, as well as leakage or regurgitation. Patients with bicuspid aortic valve also have a higher risk of developing aortic aneurysms and dissections.
Why is knowing your family medical history so important?
If someone in your family has had an acute aortic dissection, you may be at an increased risk.
If you know you're at risk because of your family history, then anytime you get a sudden severe symptom or worrisome symptom, your doctors should know immediately that you have a family history of aortic dissections, because being mindful of that is the best way to get to a quick diagnosis.
Talking with your family members about medical history is an important step in determining your risk for aortic aneurysm and dissection.
If you have a family history of aortic dissection, or a genetic condition that can predispose to acute dissection, and you're in the emergency room with sudden onset severe chest or back pain, then ask for a CT scan.
Who should get genetic testing, and how's it done?
If you have thoracic aortic disease and fall into one of these groups, we are recommending genetic testing. If you have a family history of thoracic aortic disease, if you have features of Marfan syndrome or Loeys-Dietz syndrome or another syndrome associated with thoracic disease, and if you are under the age of 56 years and have had an acute aortic dissection. The genetic alteration tells us how to manage your aortic disease. In addition, it will tell us if you're at risk for other problems with your arteries. The genetic alteration can tell us who in the family is at risk for aortic disease and who in the family is not at risk for aortic disease. Genetic testing is easy. We provide you with a tube, you spit into the tube, and then we send it off for genetic testing. It typically takes about 4 weeks to get the results back.
Where does genetic counseling come in?
Genetic counseling before and after genetic testing will help you understand the risks to your family members and the results of the genetic testing.
If someone in your family has been diagnosed with an aortic aneurysm or dissection, it does mean you're at higher than average risk. This is why it's important to talk with your healthcare providers or visit a genetic counselor to review the recommended aortic imaging and genetic testing options available to you and your family.
Anyone who has an aortic dissection in pregnancy should have someone on their team with expertise in genetics, which is a genetic counselor or a clinical geneticist, and they have specialized skill sets to take a thorough family history.
What kind of research is being done?
In the Aortic Dissection Collaborative, we are engaging people living with aortic dissections to identify research priorities based on what is important to them. This is called patient-centered outcomes research. Our goal is to understand the genotype-phenotype correlation between risk factors for aortic dissections and the outcomes after aortic dissections. This would dictate the best surgical approach in order to treat them, or if we need to use medical management.
There's an interesting study that's going on that is allowing patients to better understand what exercises are safe for us and helping patients to kind of get back to themselves. You know, there's a lot of active people who just want to have their active lifestyle again, but do it safely.
There's a significant amount of research that's being conducted for aortic disease, specifically with thoracic aortas. There's a significant amount of genetic work being done with several different research protocols being instituted. With the advent of genetic testing, we get positive results, we get negative results, and then we get variant of unknown significance. These are being tabulated in a consortium, the Montalcino Aortic Consortium, that's run by a variety of investigators internationally to collect these genetic mutations and try and identify the end results for aortic pathology. There's significant research being done in the field of bicuspid aortic valve disease, and at our institution we have a database that we're trying to correlate aortic size with outcomes.
If you've had an aortic dissection in pregnancy, or you're a person who is at risk for aortic dissection and you've had a pregnancy, there are many ongoing studies, and if you want to help, please seek them out. We do want you to participate. This is how we're going to move the needle forward, and we're going to better take care of women with these conditions in pregnancy.
I'm a part of a genetic study at the John Ritter research program, because if this turns out to be genetic, then I want to make sure that my children are tested and that they'll know that when they have children, so that they can be tested.
At the John Ritter Research Program, we're trying to identify all those genetic changes in the DNA that predispose to aortic dissections. We want to do this so in the future we can take the DNA from somebody, sequence it, and then tell them if they're at risk for an aortic dissection during their lifetime or not. And if they are, we can use that information to put them on management protocols to prevent that dissection. That is the ultimate goal of our research.